Hello again, this is Fernando Gomez Sancha. I have been out of the video production business for some time, mainly because my recorder at the operating room fell to the floor and I was not able to record the narration of the operation while I was doing the operation, and having to record this at home, it's a little bit more time consuming. So this is, but I'm back. This is the interesting case of a patient who was submitted to a TURP in the past, and he developed a stone in a bladder diverticulum. So we discussed his options. His voiding was not too bad. He was not severely bothered by his symptoms, but I told him that these stones inside the diverticulums can cause chronic inflammation of the bladder, and that can lead to bladder tumors somehow. So I didn't feel happy to leave that there, and we discussed that if he was going to go in the operating room again, it was probably a good idea to finish the job after the TURP. And so I started to use this Moses fiber to treat the stone. I was using 1 joule and 40 hertz, which is the setting that I usually use for coagulation, and the pedal. And to my surprise, there was a biological matrix that probably led to the formation of the cause of the stone, sorry. And as we peeled off the external shell of the stone, we could see that there was some biological stuff in the middle. So probably a TURP chip left behind at the time of the original TURP operation. So I guess, yeah, it is imperative when you do endoscopic surgery, especially TURP, to check inside the diverticulums to see if there's any tissue left behind, because this could be the consequence of forgetting, a piece of tissue inside this diverticulum. So I thought it was a quite interesting case to show, not only because of the stone and because of the cause of the stone, but also because I love these redo cases. I think they're very interesting. And also I think it's amazing how we can treat these cases perfectly with the en-bloc approach. There you are. So this was the fragmented stone, most fragments still in the diverticulum. So I like to evacuate fragments by gravity. I feel the bladder, I point to the stones, I close the inflow, and then I take out the internal sheath, you see. So the stones tend to be sucked or pushed out by the water coming out of the diverticulum or coming out of the bladder. Some of the stones went into the bladder, but again, I leave some time to feel the bladder, and then I like to take them out with gravity this way. It's quite, I find it nicer than using the helic evacuator or the syringe, because when you do the helic evacuator thing, the position of the scope is not known. You don't know where it is. You don't know where, if you're going to be sucking the bladder, So there were some other small diverticulums. And also I told the patient that we could try to do an endoscopic treatment of the diverticulum. This is a possibility for smaller diverticulums. So that's the sphincter. You can see there's residual tissue in the fossa. Some areas were, let's say, resected better than others. Apparently there's a favorite side for surgeons, like, remember when we did TURP, you would feel more comfortable resecting in one side than the other side. So maybe the job was better in one side than the other side. So here you can see the marking of the white line. And this is using Moses, and Moses is a pulse modulation emission mode, and the laser emits 2 pulses instead of 1. So this enhances the cutting properties and the coagulation properties. So here, you see, the thing here is you have to respect the sphincter, but you have to make sure that you remove everything. So here I'm just trying to find out what the white line should look like to try to do the most perfect possible job. You see, trying to dissect the plane was not easy, and this is mechanically, in both sides. You see, usually when you push in that region, the plane opens for you, but we mustn't forget that this man, he is a reoperated man, so most likely after TURP, the remaining prostate and the remaining adenoma probably undergo fibrosis and inflammation, and it is not unusual to find that these redo cases are a little bit difficult because of that. So this is one of the advantages of pulse modulation, I think, that the enhanced cutting properties of this laser help, in the dissection of these planes. So here I was carefully judging, what is the proper plane. I couldn't find a beautiful plane as we would normally find, and this is probably due as well to the previous TURP. I guess when TURP is performed, many glands, conduits or ducts, are obstructed, I think. And many of these residual glands are dilated, and you'll see that the quality of the plane is not very normal, like a virgin prostate that was never operated upon. So here I am trying to progress a little bit laterally as well, and trying to complete the white line. Here I didn't mark the anterior part. Initially I thought it would make sense to check as I go. You see, this is the marking I made. The other side is not complete yet, but you see how the adenoma is touching. Here, in some areas there's going to be less remaining tissue. It's going to be a thinner slice of remaining BPH tissue, or maybe in some areas you could be at the level of the interface between the capsule and the adenoma. So that's what makes this redo cases a little bit more challenging and more interesting. So here, as you can see, coming up carefully, of course, we want to protect the sphincter completely, and to be sure that the patient will have a very good continence. And here, coming up towards 12 and trying to take the working area a little bit further inside, so we're trying to get away from the sphincter, to respect it, to stay close to the sphincter the least possible time. So here again, coming up towards 12 o'clock. This was the area that was best resected. Probably I was checking the water or something. when I was stopping like that. So I took out my eyes from the screen and do something. Often you have to do that. And here, as you see, we're coming up from both sides, trying to connect at 12 o'clock and to try to develop an anterior plane. You see, this is the anterior plane now coming down. Very difficult differentiation of the plane. So I'm trying to use the energy to let the energy decide where the plane is going to go. You know, holmium laser has a very high peak power that produces this cavitation bubble in front of the fiber that produces a shock wave that is going to dilate or distend or dissect, sorry, the plane between adenoma and capsule. But here, having had a previous TURP, there is a lot of fibrosis. Still, you can see that the energy is opening up the plane, just carefully, you know, checking that it's the proper plane or very near to it. Also, another very nice aspect of pulse modulation is the nice first pass hemostasis, which allows to do a very nice operation. You can see here the tissue quality is very strange. The capsule quality is different than usual, and many times we find these dilated spaces, probably obstructed glands after the epithelialization of after TURP. So now, of course, the sphincter is totally safe, and I'm just going around trying to follow the plane to see if we can approach the bladder neck progressively. Circumferentially, you see, going around the whole adenoma. Try to follow the plane. Yeah, that looks good. But carefully, because it is important when you do MoLEP to progress and to be able to detect very early if you're going too deep in your dissection, especially when the plane is altered, like here, due to this previous inflammation. Sometimes, in these cases, you can dig a little bit deep in the peripheral zone posteriorly, so you have to be careful and progress. And if you detect that you're going too deep, then correct before it's too late. And that's why you have to be careful and keep the fiber moving dynamically so you don't stay too long in the same spot. Because if you stay too long in the same spot, you might deepen too much. So keep moving, keep trying to do superficial improvements of the dissection, and don't... here. Here's the access to the bladder anteriorly, and now we have to check. We have to check what's going on here. Brilliant. That is anterior. That's the other side. Coming up, it's always the same. Enucleation and block enucleation makes the procedure very, very easy and very safe for the sphincter. And it becomes very, very familiar and very intuitive as well, because you are just going around the adenoma as if you were peeling an orange. Of course, nearing the bladder neck, we find more fibrosis. You see, tissues are hard, difficult to cut, and but slowly we can progress. And the objective of this operation was to try to make sure that this man who was operated once and now has to be operated a second time will never need a third time if it's possible. So trying to remove the residual adenomatous tissue that will certainly grow if it is left there, maybe causing the need for a third operation in the future if we only removed the stone. So here, that is the UO, so we are quite far. You can see that the surface is a little bit rough. It's not as uniform as we are used to see, but as I say, this is possibly due to the post-operative inflammation after TURP and later fibrotic processes, and that's why we see these dilated glands and sticky parts where developing the plane is a little bit more difficult. So yeah, you always have to think, here I thought maybe I'm leaving this amount of tissue and I didn't catch the good plane, and yeah, it proved. You see that I could find a better plane. So you have to challenge your own plane sometimes. In a situation like that, you might find that you're going a little bit deep, so then you have to stop and follow the previous path. But this is the way you need to challenge and try to find what is the best plane, because you don't want to leave significant residual BPH tissue in the fossa. You see how maybe in some areas you can go near the peripheral zone laterally, and if you see that you're going too deep, then you have to correct a little bit, medialize the fiber, the incision, so the targeting of the laser has to be corrected to try to adapt to the anatomy. So this is now coming up to try to connect with the already opened bladder neck. Here we find typically this area, which is already a little bit difficult to detach in enucleation, the 6 o'clock area, between adenoma and bladder neck. Many times there's a steep curve, a change in the direction of the plan as you approach the bladder neck. The bladder neck at 6 o'clock is more like a wall. So there's a hard transition from the floor of the prostate, and then you approach this wall, and then it's not impossible. Here you can see a little bit of fat, so it's not difficult to cut through the wall and get into the retrotrigonal space. So you have to be very, very careful. Maybe take it from the lateral aspect towards the medial, trying to keep in very, very almost in contact with the adenoma, fire very close to the adenoma so that you can detach it, but not penetrate deep in this region. And this is all complicated in TURP cases because usually the middle area is the best, let's say, resected and the deepest resection area, and so it can be sticky sometimes. So that's, again, coming up from the side, trying to connect to the lateral dissection, trying to go from side to side, trying to progress. It's a matter of improving the situation every minute. It's a matter of patience. You shouldn't hurry, just take it easy, progress slowly, and this will take you to the fastest possible result, I think, if you are careful and you progress without compromising the procedure and take your time to cut and to dissect carefully. Also, if you see, as we have seen, a little bit of fat in a small area, don't panic, just keep working, correct the plane. Usually it has no consequence to go a little bit deep in a region of the capsule. It's important to stop in time so you don't do a massive perforation, in which case probably it's better to put a catheter and come back another day. But here we are progressing. Now the adenoma is tilted into the bladder, and there is the bladder neck that we have to cut. Very fibrous tissue, but nearing the completion of the enucleation of the residual tissue after TURP. So here you can see how the bladder neck is completed and the adenoma is pushed into the bladder. That's the sphincter. We have managed to preserve the sphincter beautifully, and there is some minor residual bleeding. That's a small nodule, so I'm going to vaporize it. You see just below the nodule it looks a little bit flimsy, so you can spend some moments to make sure that you vaporize these small nodules like that. Some vessels going, not too much. The next thing I'm going to do is I'm going to try to get in with a biopsy device to take biopsies from the mucosa of the diverticulum. We want to see if these changes we have seen in the diverticulum, and that's the adenoma. You can see that it's a donut, it's a circumferential piece. So we have managed to do an en bloc enucleation of the residual tissue after TURP. This is an unedited video, so I'm not cutting anything, just showing you the real-time work. And here I changed, I think, no, and the next thing, of course, we're going to do is the morcellation of the piece. So here I changed to the morcellator. I was trying to say that the plan was to take a biopsy of the diverticulum. I tried to focus for a moment, and often this post-TURP tissue is also very fibrous and sometimes difficult to morcellate. There's a lot of fibrosis. It's tissue with the consistence of leather, it's very, very difficult to cut. But in this case, it was not so bad. Just took a little bit of time to morcellate. Just have to be careful to keep the bladder full and to keep the blade away from the bladder wall. But this is the Piranha morcellator. I love it. I think it's excellent, really fast, and it really, really helps to have a good morcellator because it shortens the operation time significantly. Here you can see that we did the stone in the diverticulum and the enucleation. It's been now 24 minutes. So these operations are not lengthy anymore because mainly because of the morcellation. But I have to say that after using pulse modulation, we have noticed that we are faster because we don't spend too much time in hemostatic maneuvers during enucleation. So we can just go, dissect, and enucleate, and then we don't have to spend a lot of time doing additional coagulation. So this is the end of the adenomatous tissue, now coming out. typically the morcellator choose the easy parts first, and the fibrous parts are more resistant, so they're left for the end. And this is when we have these beach balls that are a little bit more difficult to morcellate. But in this case, it was perfectly possible. That is one of the diverticulums. For a moment, I thought, would it be possible to suck the diverticulum inside the mucosa, inside the bladder, and then morcellate? Just a crazy thought. I thought, let's better not do that. And then, of course, we changed. Here you will see there's a little bit of bleeding, and that's because we decompressed the bladder completely. And of course, I didn't spend probably enough time to do perfect hemostasis. But I thought I'm going to come in with our resectoscope. So there you see there's some accumulation of blood. Here I think I was going to try to take the biopsy from the diverticulums. Just found the diverticulum. Look at these changes, you see. What is that? So I'm sorry for my voice. Here I think I was trying to put that's the bladder neck. Where are you, diverticulum? For a moment, I couldn't find it. So I took out my view from the diverticulum, and then I had to put the biopsy forceps, gold biopsy forceps. And there it is. And look at that. Stones inside diverticulums are not good news. So I decided to take some biopsy to send to the pathologist. And then, of course, the other interesting point of this video is that I'm going to try to do the endoscopic treatment of the diverticulum. You can try to treat this mid-sized diverticulums endoscopically. And how is that accomplished? Well, you have to go back to the old resectoscope. And I thought this was the third, sample. And as I said, we're going to change now for a resectoscope. See, there's a light hematuria. Usually, if you put a catheter, that completely stops, and it's not very relevant. But as I was going to go in with a monopolar resectoscope, I thought there's no need to be very, very thorough with the hemostasis, and we can finalize with the resectoscope. You see, also, of course, this tissue probably is more inflammatory than usual, and more prone to bleeding a little bit. So I thought, let's spend 2 minutes perfecting hemostasis in the fossa, and then I will go to the diverticulum. Many times I think these bleeders, for some reason, when we put a catheter and the prostatic capsule collapses, they tend to stop. And it is the distension of the fossa that keeps them bleeding. That's the venous bleeding. If there are small arteries, of course, it's a different matter. But yeah, nothing serious. So I just wanted to have a little bit better visibility in the bladder. That was clot that was already forming. This is bladder neck. Okay. So now where are you again? Here. So this is the interesting part, I think, of this video, and this is the endoscopic treatment of a diverticulum. Hoping that this is only inflammation, I'm going to fulgurate the whole mucosa of the diverticulum. And systematically make sure that all the mucosa inside the diverticulum is fulgurated, coagulated. For some reason, I didn't think about doing this with the laser itself, but which probably it's a possibility. Just photocoagulate rather than electrocoagulate. But here I was trying to remove the inflamed mucosa, and the idea is that if you coagulate the whole diverticulum like that, and you keep a catheter for 3 or 4 days connected to a bag, so the bladder is empty, this sticky surface is going to remain collapsed, and possibly it will connect again. This perivesical tissue will connect again with the bladder wall, and when reepithelialization takes place again, the size of the diverticulum will be less than the original. This is the endoscopic treatment of bladder diverticulums. So here I'm trying to see that all the wall of the diverticulum is fulgurated, and if I have a chance to scope the patient in some other moment, I think I will try to add or connect some further information to this video to see if this really works. But you see, now with the mucosa totally gone and the bladder totally empty, it's very likely that we will there were some stones there, so I did the same maneuver again, just removing, you see, the inner sheath, closing the inflow and letting the gravity or the outflow, the water from the bladder, take out this remaining stones. Searching for other diverticulums. This is the one that I already treated. There's a small one there that I lost. This is another one, so I'm going to try to do the same here to see if we reduce these diverticulums. And I hope it works. I think it's interesting to see how TURP, that is considered by many as the best endoscopic treatment for BPH, also has its problems. And in this case, this man has a stone in a diverticulum due to a forgotten chip of tissue inside the diverticulum. A stone has formed, and an inflammatory or maybe dysplastic changes have taken place in the mucosa of the diverticulum. So this is my treatment for this case. The 2 diverticulums are fulgurated, coagulated, and we will keep a catheter for 3 days, 4 days to see if we can end with this or improve the situation. I hope you enjoyed the videos, and thank you very much for your attention once again.